It's my pleasure to introduce to you, and of course, really, he needs no introduction to us, but for some of you who may have missed Dr. Kerr last year, he's the Chief Medical Officer, Chief Executive Officer for Hospice and Palliative Care Buffalo. Chris earned his MD and PhD in neurobiology. Alongside direct patient care, his focus is in the areas of leadership and patient advocacy. His passion is palliative care, with the belief that such care should be provided throughout the continuum of illness. Under Dr. Kerr's leadership, Hospice and Palliative Care Buffalo now serves 1,000 patients a day? About 1,100 patients a day, half of whom receive services prior to hospice. So help me in welcoming Dr. Kerr and thanking him for coming here.
Oh, thank you for having me. Just so I'm clear, how many folks are purely hospice affiliated? Oh, great, I'm speaking to the choir. I wasn't sure, so some of this will seem rudimentary at the beginning, so we'll just blitz through it. So our organization has been doing palliative care in the hospital since 1978. We were the first ones, actually. And we've been doing home-based palliative care for adults for probably 13, 14 years, and pediatric care for almost 23, 24 years. So what I hope to do is just make the case statement for palliative care as provided by a hospice, and why that is becoming more necessary. So this isn't probably one of these things that isn't necessary, but obviously palliative care is aimed at enhancing quality of life for those with serious or complex illness. It's whole-centered, including family, in the place where they live, etc. It involves addressing all dimensionalities of illness, psychosocial, physical, practical, etc. And it involves informed consent, information, transparency, and all that good stuff that really baked out of hospice. And I think that's one of the premises of this talk, is that this actually grew from hospice. Palliative care didn't grow external to hospice. It's actually our model of care. So obviously palliative care is more than hospice. Hospice is a subset predicated on the diagnosis, the probability of 6 months or less to live. It's obviously it's a benefit, it's a place, it's a philosophy, but again, palliative care itself is much longer. So the distinguishing features between palliative care outside of hospice versus in is that it's appropriate for any age, at any phase of illness. You can come in and out of it, the waxing and waning approach. It can be provided alongside curative care, and it's not predicated or dependent on a diagnosis or a prognosis of terminality. So why is it necessary? The data here, this is a lecture actually onto itself. It's a lecture that will make you weep, because when you look at the data in terms of how our patients suffer and what our families feel about the care they're receiving, particularly hospital-based, it actually hasn't improved over the decades. Are people familiar with the support study? It was a landmark study that was done in the 70s. It was really instrumental at the time for propelling the hospice movement, because it showed the severity of symptoms that people were suffering with, the lack of information patient families had and loved ones had, their satisfaction with hospitals as a last place of care. Basically, it was a damning statement. It was it portrayed or left those dying in sufferable states that were unimaginable, and in the overwhelming amount of cases, this wasn't treatment failure, it was actually just a failure to treat. So the data there, again, isn't getting any better. Care is not less fragmented, it's probably more fragmented, and there's interesting research that says the more people involved in the care, the less people actually know. So more chefs in the kitchen kind of theory, and that's true. Families and caregivers are overwhelmed. This is becoming more and more the case. We're the primary providers, particularly with the gray tsunami and dementia, and the numbers in terms of the economic injury to people, loss of life savings, the impact on the health of the caregiver, et cetera, et cetera. It's not getting better, unfortunately. I could go on and on about the extreme misuse. Anybody know what percentage of GDP is spent on healthcare roughly? Like 19%. At this rate of growth rate, our grandchildren, the vast majority of the GDP the gross domestic product for this country will be geared towards healthcare. So we're in an insolvent model. It works remarkably well if you want to create an economy, like a military-industrial complex kind of economy, but not if you're trying to serve the needs of a population. And palliative care, and this is a critical point, our patients are the patients that are the highest spend patients, okay? So the costliest 5% of Medicare spenders are now 43% of the consumption of the dollar. And that's the palliative care. 35% is in the last 6 months of life, and a third of that is in the last month of life, with most people having at least one ER visit. And interestingly, the outcomes aren't better. In fact, the outcomes are worse. You go towards tertiary centers. So you've got an inverted value equation. You're paying for more, but you're getting less. So it's a model of care that doesn't work. And again, these are the folks that we need to be taking care of. The chronically ill is becoming more so. The amount of people who are 85 and older doubled between 2003 and 2030. And illnesses changes. You used to die from predominantly one disease, a cancer. Most of us will have 3 to 5 diseases. So it's about living with a bunch of chronic diseases. So a lot of diseases that were terminal now are just disease burdens that you carry with you. Why should a hospice, and this is my big thing, why should a hospice be providing upstream palliative care? Because, and I'm a pure hospice person, but there are issues with the hospice benefit. One, it's predicated on prognostication, and who thinks doctors are good at prognostication? There's a lot of math done on this. A lot of papers on this, and basically, if you're trying to narrow within 6 months or less or after, you're better on probability to flip a coin. And what's really interesting is the people who are most accurate, which is the older, more experienced physician, are also the guys who are most likely to disclose, least likely to disclose. So yeah, it's obviously problematic, and truthfully, people don't always hear what they're being told. In fairness to a lot of physicians, we put people in a terrible choice, where you need to give up something to get something. And the drug du jour changes all the time, but it's very hard to keep up with big pharma. Hormonal therapy is the new anti-hospice thing that we're dealing with in our area. Some of the data on it isn't great, but the risk-benefit of popping a pill like a vitamin with very little side effects, people understandably are going to take it, but it's cost prohibitive for hospices. I don't know about you guys, but nationally, more or less, and for us, the hospice length of stay isn't budging. A third of our folks are a week or less. And I think some of the, I suppose this one, I did, one of our best uses, which I'm going to argue later, is actually helping people in that transition from curative to non-curative care. And we'll get to that. So in terms of the margin, the hospice benefit is being squeezed. We're being asked to do more with less. Just look at what we're having to cover with drugs, the need to do face-to-faces. I don't know about you guys, but how you run an inpatient unit is becoming ridiculous. So it's getting harder to do our work, and I think that's going to be the case going forward. There's competition. We never had competition. You may not feel you have competition. Let's say if you're like us in a certificate of need state and there isn't actually another hospice, there actually is. They're doing palliative care. So in our area, venture capitalist dollars from California came into our neighborhood, and it's very simple. They just approach the insurance company and they say, give us your top 5%. We're going to overlay a super supportive home-based care with 24-hour services. We've got x-rays, labs, nurse practitioners, and you're so costly. Let's put it this way. You assume the premise to be true, that we're wasting an enormous amount of dollars on real sick people frequent flying into hospital. That's also an enormous opportunity in terms of margin and cost avoidance to make money in a shared savings model, right? You can give a lot of home care, and you save one ICU stay, and so that's how this works. It's competition because whether intentional or not, they end up holding on to those folks longer. So in our Landmark is the company that's in our town. And what happens is if you're a patient entering Landmark, you are less likely to enter our hospice than if you were outside of Landmark. So again, my argument is if you're not doing, somebody else is, and if they're doing it, very well is going to hurt your hospice. The patients we see then often are difficult. They're concerned about some kind of drug divergence or dependence, etc., or they're coming in brink of death. So palliative care not provided by us is harmful. And then frankly, we've gone, and I'm going to make this argument, from being a fringe cause. I've done this long enough that I used to have to go around and tell people how to say the word palliative, and now it's so popular. Who doesn't do palliative care? I don't know if you know that, if you have that same issue here, but we've got an abundance of palliative care. Now there's market advantage to it. Nursing home will say, we do palliative care. And that's actually a problem because it's so loosely defined. Go up to a doctor and tell them that they're not trying to enhance somebody's quality of life. Unfortunately, there's no quality measures. So the first wave of palliative care was really simple. Go to where the misuse and spend is and the need is the greatest. We have one hospital that is a catchment for 13 nursing homes, so it's not uncommon to go to the ICU and see people intubated at 92 who clearly weren't going to come out of this stay and probably may have not had wanted it. So very simple. The symptom profile in the hospital is bad. People needed it. The dollars are being wasted, and there is an abundance. The references for this page I actually took out because they're so expansive. But Diane Myers and others have done just an abundance of work and made the case statement. The value equation then is quality over cost in terms of quality, symptoms, quality of life, length of life, which we'll get to, satisfactions in the high 90s for referee, patient, family member. And again, you're lining outcomes to actually what people want. In terms of cost, it's overwhelming. You just reduce the overall stay. And I'll talk about that because we published one of these studies. And then this is a big one, things like 30-day readmissions. In old world healthcare, raw fee-for-service, kind of Wild West stuff, you could go in for an MI, go to a parking lot, fall down, have another one, go back in, and it would start another billing cycle. Now you get punished for people. So there's ever more awareness that you have to be responsible for the continuum of one's illness, not just an episode of one's illness. And then, of course, hospitals are concerned about mortality. This was a landmark study that actually showed what we all knew, that what we were doing actually enhanced quality of life, lengthened quality of life, same as in hospice. It makes abundant sense, so we don't necessarily treat the primary disease, but boy, if you're less nauseous, if you're sleeping well, and if you're comfortable, you're going to be more functional eating, you live longer. It just makes sense, and this has been repeated since. This is a study we did in our own hospital, and so we matched our folks. It's called propensity matching. So you match a patient based on bad outcome and cost to a control group. And actually, we saved more than this because we get the sickest of the sick patients, and we couldn't find enough of those to match with. So this underreports actually the savings. But you're looking at $1,400 per admission. And this isn't really difficult stuff. It's having an actively dying patient not receive another interval check of an MRI. Sometimes it's getting to the family quickly. So we've got lots of cases where the pathology report's there, the imaging results there, but instead of waiting 3 days to have a family meeting, we're having it that day. So it's actually synthesizing information, it's sharing it with people so they can make timely choices that are actually consistent with what they want. So again, this is low-lying fruit stuff. But it's also very discouraging work because when you're seeing that 90-some-odd-year-old in the ICU, you really need to be upstream before the accident happened. Again, you dropped readmission rates tremendously. If you look, though, the palliative care folks actually come back higher because they're often the sickest and most challenging. If you do hospice at the back end of the palliative care, they don't come back to hospice because how often does one of your patients in hospice go into the hospital? Essentially not, right? So we're the foolproof cost avoidance model, and that's an argument for a hospice doing palliative care. So really this second wave of palliative care, the first wave being the hospital. The second wave really needs to be home-based. And a couple arguments. The infrastructure of hospice is entirely in the home. You've got the call systems, you've got the skill sets, you have the disciplines, you have the deliveries, you have all that's necessary. And the hypothesis is really simple. It's what the insurance company wants: better quality outcomes, fewer high-end utilizations in terms of ER and hospital admissions, lower costs. Benefit to the hospice is huge. One of our, and I can say this to our crowd, when our hospice is 43 years old. When we started, I think for the first 30-something years, the mantra we used, and certainly I worked for a long time under this idea, is that we were going to go and argue our cause. We were grassroots-based, we were community-facing, we were advocates, and we were going to tell people, you need to do this, you need to bring us your patients, just call us. We were available, accessible, willing, all of those things. But we only got so far. There's always a subset of patients who won't access, subset of doctors who won't refer, and I don't think what we've done enough is let go of the brand and really wed ourselves to the model of care, no matter what you call it, to get upstream. That's basically my argument. Because again, we're going in the wrong direction actually in terms of length of stay. Benefits to the family and patient are obvious. So this is our model. We call it Home Connections. We've had it for 13 years. In this version, it's for the adults. This is an interesting story. This actually started as an MD model, and we've had a few rounds at the bat, and that was the unnecessary piece. The successful piece to this is a nurse social work model. And for a variety of reasons it'll make sense. We have a lot of NPs now who go in there, and they're really doing the part where the doctor in the community is drug phobic on something, or the patient can't get to the office. So there is a role for NP and physician involvement, but this is largely a nurse social work service line. We have interdisciplinary team meetings. The key part is you're 24/7. So if your hospice patient is brink of death, then automatically there's a lot of your palliative care patients who are actually hospice patients. So it is not uncommon for us to have a Home Connections palliative care patient admitted on a Monday and in our unit and actively dying by Friday. So one of the things that differentiates you from the for-profiteers who are doing palliative care is most of them don't do the 24/7 piece. It's just too costly. And so that's one of the reasons you should be doing it. We get a per member per month. We get X amount of dollars, and I'll just say from the onset that when we started this, value-based health system wasn't a thing. So now it's a big thing. So now you get paid profitably for doing this, but at that time we didn't. But we were net neutral in the provision of home-based palliative care, but we were net positive when we saw how many billable hospice days there were, because a lot of these people are coming into hospice. So our first paper, we looked at the clinical outcomes, and this was kind of interesting. So 71% of folks completed actionable advanced directives. If that's the only thing we achieved, that's worth millions of dollars. So I don't know how much you know, but any given state will put millions to invest in advocacy and methods to get people to complete them, because they're actually shown to work. They work in terms of outcome for the patient and family, but they're enormously cost avoidant. So we essentially doubled where people were coming out in terms of their actionable directives. Nearly half of our folks died at home, and that's huge. These numbers are old actually, because the newly reported data is more people are dying at home, right? If you had a symptom, lo and behold, it was better managed, which I would expect. And this is what's interesting, is that the people who came into hospice, so roughly, and if you remember nothing else, remember this, Of those discharged from home connections, 40% end up coming into hospice. So it truly is a pre-hospice program. And of those who came in, on average, they're at 1.5 times lengthier average length of stay into hospice. So one referred palliative care patient is worth 1.5 non-palliative care referred in terms of billable hospice days. So that's a lot. And then the satisfaction scores are enormous, usually around 95% plus. And the reason is, it's not because we're so great, it's because you're comparing it to nothing.
Or the hospital.
Right? I mean, there's no like model for this for people in their homes. So that's why it works so well. So in terms of the cost savings, in the last 3 months of life, so the closer to death, if you use death as an endpoint, you're saving a considerable amount of dollars, $4,000 per member per month. During the last 2 weeks of life, it was almost double, because again, that's when the expense comes in. And again, is the enhanced hospice entry, and that's cost savings to the payer because you come off the dole. Right, as soon as you come into hospice, is basically a capitated model of payment. You go into hospice and you're set up. So here, towards me, the x-axis, that's 2 weeks before death. So the greenish yellowish line is the control group. Again, the propensity matched. The blue is the home connections program, and the little difference in between the blue and the red is the cost of the program. So the big delta, right, is between the blue and the green. As you can see, you're talking as much as $6,000, $7,000, $8,000 as you get closer per month as you're getting closer to end of life. And the relative cost of the program is peanuts. This is an intra-group comparison before and after coming into hospice, and you can see a dramatic reduction in ER utilization. Just going to go off a little bit and talk about pediatric care, because unfortunately, too few hospices have attempted this. There's NHPCO just filmed a video at our place I think is going to be available in the next couple of weeks. It's really interesting. So yeah, we've been doing this for almost 3 decades. And a really interesting history. It was our children's hospital had a light program, and then they didn't want it anymore. It was costly. We took it on. Our foundation supported, cost up to about $1 million a year. But because we had the adult program, we went to the payers and said, well, if you're paying for adults, why won't you pay for kids? So we got the payers to pay for it. And now we've got Medicaid to start to pay for a lot of our services, including things like expressive therapies. If you think the cost avoidance is impressive for the adults, it's actually more impressive for the children. The need profile is as dramatic, but the frequent flyer miles into hospitals. We've got one child who is 170 times ER hospitalized the year prior to program and 7 the year following.
Wow.
It's just they just don't know what to do. And they often have other children. A third of our families are completely broke. They're below poverty line. Oftentimes they'll have multiple children with disabilities. So it's incredible. Our program, for those who are interested in sort of thing, is actually, we used to have it under a child license, but a child license really limited us because they tell you why you can go see a patient. You had to have a skilled need, Foley, IV, wound, whatever. And actually, it's palliative. So we couldn't see people for the true need. The mother who's breaking down in the middle of the night, can't do it anymore, screaming child, that kind of thing. So we took it out of the CHA, and we actually got rid of a person who was just doing the regulatory component, and we put it under a doctor's license. It's no different if you have a physician's office and you hired a nutritionist. So we do this, which is great. It allows us to determine our best use. So, and you get way away from the regulatory piece. A huge success is our perinatal program. So these are folks who know there's a high likelihood of a baby born with complications, or there's going to be fetal demise. And we're involved early, and it's an unbelievable program. it takes a tragedy that is, it can be medicalized and empty, loss of a baby, it's just done procedurally and you're done, and it becomes something totally different. They have all sorts of meaning-making things involving the siblings, heartbeats that they put on recorders, pictures taken, special coffins often taken home, grandparents coming in, all of these remarkable things. Actually, the young fella who is featured in the NHPCO video was born with anencephaly, microcephaly, a lot of his brain was missing, and he was in the hospital, and the cost avoidance is huge, right? You're in a NICU. And they just want to take him home. And that was September of 18, and he's still alive. And what's wonderful is, he's different looking, but when our team's there, she gets to be a mother, everyone wants to hold him, and he's just a remarkable little fella, and that's who's in the video. So anyways, we got a lot of support for this program. Unfortunately, it still loses money because we reinvest in it a lot. I can't emphasize this enough. The medical component is a relatively small component of what we do. So big and expressive therapies. You're talking about children without language. You're talking about siblings with limited insight or conversations around this. So art therapy is huge. Movement therapy, massage therapies, those guys are big. Spiritual care component obviously is big. So it's mixed. There's still doctors and nurses and all the other stuff, and that is really important, but it's more, there's a heavier proportionality on the non-medical piece of it, so it's costly. And but people are starting to recognize that. So Medicaid, for example, as I said, was explaining for our expressive therapy program. The cost avoidance, we haven't published this paper because it's extraordinarily hard to find comparison groups. But this is one such young lady who's 4 years old, and which you can see a multitude of medical diagnoses that would leave somebody stuck in a hospital. And she was actually hospitalized from birth, but we got her home. And obviously it took a tremendous amount. We work with CHAWS, but we were able to dramatically reduce her ER visits and hospitalizations. So it works. So the lessons learned. So the key is well-trained nurses and social workers from the hospice side. It's taking that skill set. We've had a much harder time, although we have had some great outcomes of taking people off the street who are not doing hospice, but it's easier. The variance is incredible if you take somebody who's done this work, and we see it actually when the for-profits just flick a switch and create it non-organically. The outcomes are very different than what we're doing. You got to be 24/7. These folks are really, they're sick as sick gets. Social work is huge, huge. We did one of the Medicaid design projects. Are you familiar with those? Because California had a project. There were several states in the country where the state government put a lot of money into redesigning how we do Medicaid. And basically what they did is they invested in things that aren't valued in fee-for-service: behavioral health, perinatal care, behavioral health, drug abuse, you name it. So palliative care was one of the beneficiaries. What we found was the closer you got to that work, we had to basically double up the social work component. And thankfully, there's a greater and ever increasing recognition of the role of social work. Basically, if you, in a value-based health care where you really want to change outcomes, you better pay attention to things like health literacy, issues of compliance and access, all of these other things that are so critical. You just can't look after body parts. And that's kind of the take home. And that's what we found with our program. The social work piece is humongous. I wish I had a tape of some of our staff. Actually, one was lecturing this morning on this. We like to talk about doing things like advanced directives and choices like hospice as though you can do a flyby. Do an intersection and people are going to change life choices. It doesn't really work like that for a lot of folks. It evolves out of conversations and a relationship that takes time. So we've got people who actually, great story of somebody who wouldn't let their advance directive, they didn't want invisible sight. They could put it in the foyer at a table where they didn't have to see. And gradually, after the nurse and social worker got it closer and closer and closer, and kind of 3 weeks later, it gets signed. You can't do that in a 15 minutes office appointment. So that's really my point. What works best is having hospice at the back end. That's actually the safety net here. That's actually the cost avoidance. So that's transition. And I honestly argue that that's some of our best work, is helping people in that transitional piece, and we're really well equipped to do it. The care need to be guidelines. The definition of need is variable, and it needs to include all sorts of things. So you may have somebody who's less sick, but has less ability to be sick in terms of support mechanisms, understanding, access, etc. So you need to do that. We use a ton of predictive analytics. That's more and more in vogue. So basically, if you take 10 doctors, their referral rate into hospice and palliative care is going to be variable, right? So recognition of need, ability to have conversations, time to have conversations, all those things that are necessary. So the more you can take it out of their hands and actually use analytics. So what we do is we run these reports. So the doctor comes in and they've got a panel of 10 patients. There'll be 3 labeled. These people need a palliative care discussion. What we do now is we embed people in the office. We tried to do the whole skill set transfer thing, and that didn't work so well. They're just too busy. Who's going to stop and have a half an hour, 45-minute discussion with a patient and family? So what we do is we have, at our bigger practices, we have staff who go there, that's where they go to work. And when the doctor can do the intro and say, look, there's somebody I want you to talk to, I'm concerned you're going to need more help, here's so-and-so, and then we come in and have the conversation. And truthfully, we're better at it. This stuff in the office doesn't work unless you have a champion, and it does not have to be a physician. In fact, I can give you an argument as to why it really needs to be a nurse-led champion. That nurse who knows the patients, knows the families, knows what the folks are dealing with, the home, et cetera, et cetera. The last thing is just there's enormous opportunities happening with reformed healthcare, with value-based healthcare. So our new contracts, I think our palliative care census is 550-600. I think it's going to get closer to 1,000 by the end of the year, which is really going to be hard for us to cope with. The reason is because everybody wants to avoid utilization. So I'll give you some examples. So our big practices were just recently bought. No longer fee-for-service, outcome-based. So if you're a primary care doctor, in the old where you used to get paid for how many visits you had in a 6-month period, they don't care. You can see that person every day for 6 months. That's not going to get you more money. What's going to get you more money is that they were safe and home, that they got appropriate additive therapies when necessary, they avoided avoidable ER visits and trips. They didn't go fall and go boom. Those are the things that really matter. Again, so this has gotten very, very popular. So we just signed a contract last week with a large accountable care organization. This is a group of folks who's looking after 17,000 lives. It's a cohort of physicians, and what happens to those patients matters in terms of how they're going to get paid. I hate to sound crass about this, but honestly, if you follow the money, you can follow the interest. And so we're going to be doing that. Starting in April, we're getting 170 more lives. And again, it's not hard. And you're not waiting for a clinical judgment anymore. They're just going to take this top tier of users. We're also aligning with a healthcare system, and we're doing more and more telemedicine, which is really helpful because we're not sure how to get to all these people. So lots of opportunities. The embedded model works, ACOs, the DSRIP is a Medicaid redesign. We're partnering with a CHA, actually. They do the skilled need, we do the palliative need. Use a lot of analytics. Again, 30-40% of our palliative care patients are coming into hospice. If you're not doing it, somebody else will. That's it. So, does that make any sense? Okay. Any questions? Yes.
I'd like to look into that study that you mentioned in the beginning, the support study
Yeah.
from the 70s.
Yeah, 70s, 80s, yeah.
Is there?
It's famous. If you look up, it was published in JAM. If you look up support, it was an abbreviation,
Got it.
SUPPORT, and it was really the first study. I think it was like the National Institutes of Aging or somebody did it, and they really wanted to know how people were dying in hospital, and they weren't expecting what they found.
It just clicked for me. I've had so many patients recently share their experience with a loved one dying, like in the 70s, you know, like they were in their 30s and their partner
Yeah.
died, and just describe it as the most awful thing they've ever experienced.
Yeah.
And like, I will not let that happen to me. But it just clicked of like how bad it really.
Yeah, what's like people who you talk to, right, who still remember really bad nursing homes as warehousing and people in hallways and stuff, and they're traumatized by what they saw. Yeah, but look up the support study. It's really interesting.
Another question.
Yes.
Are you guys accredited by is your agency accredited with the Joint Commission or any other?
No. You know, that matters a lot to hospitals, I think, to have an accredited palliative care thing. But it actually matters less. I know in my sense of it, 15 years ago, 10 years ago, I think it mattered a lot. It depends on what quality metrics you're using and things like that. I think where it's good is it gets a hospital to invest. Because it matters. Then they can say, hey, we've got an accredited palliative care, and they usually invest more.
Payers are requiring it too.
Are they?
Yeah.
Yeah. Interesting. Not in our neck of the woods.
I loved how you emphasized how important social work is in the palliative care.
Yeah.
All the different approaches, whether in the hospital or in the home, or with children. It's really wonderful. Do you have a sense in your organization of kind of maybe having a bigger proportion of social workers than you might have had 10 years ago?
Yeah, and in fact, we just last week appointed a VP of psychosocial services, who's now on the same tier as our chief clinical lead. And we did that for, here's just my CEO hat. I did it for a couple of reasons. When I got to hospice 20 years ago, this is interesting, we started our IDG meetings with bereavement, talking about the people we lost as people and their families, right? And then we went to volunteers, and then we went to social work. What's happened is we've become so regulated. So this isn't anybody's fault, there's just system change. We became so regulated, and the EMR has so utterly ruined human discussion that what we do now is we throw up a template and we go through boxes that are clicked, which doesn't reconstruct a human. And so my point is that what's happened is inadvertently, hospice started as a rebuttal to a pure medical model in its worst traditions. And what's happened is we've become progressively more medicalized through regulation and EMR and compliance. What's happened inadvertently is our brethren on the psychosocial service side have lost a lot of the voice in the room. Because I can tell you, because I was there, they carried the room in the old days. And that's not happened. So what I did was I made, she's an expressive therapist, and she's now the VP of Psychosocial Services. She has overriding reach of everybody, including bereavement, because I want them to be elevated, protected, and that kind of stuff. Our bereavement program is huge. We do a lot of non-hospice community-facing bereavement, like SIDS, violent death. We do kids camps, playback theaters, all these kind of things, and that needs to be more. And the timing's right, because the granting organizations are asking for this. The demonstration projects are asking for it. It's like I was saying, there's a recognition if you want better medical outcomes, treat all of the person. And so I think the timing's right. Yeah. Yes?
So my question is a little different maybe, and just something maybe just for you to consider. As one of the nurse champions that you talk about, it's compelling to me to think about what, because you do analytics and we understand costs and things. Money is a big part of what we talk about now in our groups. But it would be intriguing to me to understand what you would imagine the percentage of our hospice money is spent on the actual physician nurse, chaplain, social worker, you know, on their money versus the whole machine of hospice? Because I, like you, have seen this 20-year change where it seemed like we were talking less about money and how much reimbursement was and how much, you know, keeping costs in a certain parameter, and more about, gosh, should I accept a 2% wage increase this year because it's for the right reason? You know, now it's hard for me to wrap my mind around the understanding that with all of the business, what percentage is being paid to the top people in the organization, or the top, you know, the whole administration of the hospice model, versus what the core people who actually.
Well, I can tell you that the proportionality of the non-core spend is going up. Unfortunately, I don't know how you get away from it, because, like, I used to laugh. I'd go to hospices and there were titles I never even heard of.
Right.
But, you know, as we become more aligned with mainstream healthcare, you need that kind of business development person.
Right, but I mean, what percentage would you say is the actual kernel cost of?
Oh, I don't know.
Like, what drop in the bucket are we actually?
Yeah.
You know, when you really think about it.
Yeah, I don't know, but I tell you, it comes up because whenever we get a census squeeze, we start to look around at each other, is what's mandatory frontline service versus what's the goo. The one that bothers me the most, I think, is the IT spend. Because, and I'm not insulted, I don't mean to be rude to anybody here who's IT, but, you know, my Lord, I just wrote the check for the security, the cybersecurity, the insurance on the cybersecurity. I mean, we've created our own economic system for, and I'm not so sure there's a net benefit. You know, there's a lot of distraction. What I feel sorry for is a small hospice that are doing they can't afford a clinician, but they have to do face-to-faces. That things like that are because we have most of our hospitals in New York don't have a physician.
Can't even afford a physician.
No, but now you're required to do 30-day.
That's my point, it's like we're missing the core idea.
Yeah, but you know, if a lot of what happened is, because I've watched this, when I started at hospice, 2% of hospices were for profit, right? And now it's closer to 70.
Yeah.
And this is what drove, and you know who some of the largest ones are, right? Like Chemlon? I'm serious, Chemlon is in the hospice business. And so what's happened is that, I'm not saying all of them, but there was certainly a subset that you know, there are hospices who had HI or inpatient unit length of stays of a year. So there was abuse of the system. The abuse appropriately brought the scrutiny. The scrutiny and compliance is costly.
But now we're way over.
Yeah, we are.
Way over.
But you know, I don't know if you guys, how much you're doing this, but this is important. Look at what's happened in the national press to hospice in the last 12 months. I mean, we get slaughtered all the time. But if you look at it, they usually don't distinguish between profit and non-for-profit, and that's the difference. Yeah.
I have a question about ratios. So in the palliative care home setting, is there, you think, an average ratio of a full-time nurse to a number of patients, or a social worker caseload? Like, what are the?
Yeah, I can tell you exactly what they are. Yep. So non-Medicaid, it's about 35 to 40 is an upper limit for a nurse caseload. Okay. On that sounds high or low? High. But again, when you take we're talking about palliative care. We're talking about hospice, you're talking 12. Yeah, you got these folks are different, right? The other thing you have to realize is almost all of them are still seeing their doctors, like regularly. And I can tell you that our model flexes. So you may be a patient that gets seen once a month. You may be a patient that gets seen 4 times a week. So, and I will defend that to the end, because that's actually, we flex to need. So we don't have pre-prescribed visits. So a nurse may have to drop to 25 depending on the acuity and complexity of the caseload. So that's the model. You have to understand, hospice pays, depending on where you are, let's say $240 a day, right? You may get for a palliative care patient $500 for a month.
Yeah.
Right? So it's a lot of surveillance. It's a lot of we'll get to you when you need us most. It's that kind of approach. On the social work side, it's closer to 1 to 60. In the Medicaid, it's half that. It's absolutely half that. Yeah, but there's patients you're going to go to, and they're going to meet you in the driveway with their golf bags.
Oh.
Okay, so it's a really, really mixed population. Now, you're going to, on that panel of patients, you may have 6 that are absolutely should be in hospice, and you're going to be there all the time. It's also no one's going to pay you ever in this world what we get paid for. People don't understand. Hospice is the richest benefit in healthcare, period. That's why it'll forever be scrutinized. So you're never going to get the fee-for-service side, the payer side is never going to pay you that amount on a daily basis to provide palliative care. So we're fortunate to get what we have. But that's why we work so very hard to get people into hospice, because the richness of the service is you can't compete with it. Yeah.
What's your MD ratio?
It's varied. I think that we have essentially 4 people, so about 1 to 100 right now. But again, a lot of them are seeing their own doctors. Our doctors, here's where our doctors and nurse practitioners play really important roles, where there's a misalignment between the reality of the medical situation and what they're being told or not being told by their providers. Okay, so and sometimes this isn't anybody's fault. They just haven't been back to the office in 5 months, or that the doctor thinks that they're doing better in the home than they are. I mean, we see people who are literally trying to crawl upstairs who are pooping in buckets, and the doctor's office doesn't know what they're contending with.
So are you a consultation service?
We're a consultation service, but we triggered for a variety of reasons. Patient, family. Oftentimes, it's the nurse actually. The nurse practitioner relationship is very interesting. They'll say, I'm really having a hard time getting them to understand that, this man's wife is truly dying. She's lost 30 pounds in the last month. She's not going to make it back for her next appointment, and there needs to be another conversation. So they're kind of supplemental. And they're mostly on the communication side.
Do the doctors supplement?
Our folks are coming in to reinforce what the nurse social worker is trying to get the patient and family to understand.
They're not seeing every patient. They're not.
No, not at all. Not at all. No. Some of them are actually not going into hospice because they want to hang on to that relationship with that doctor they've had for 30 years. So another subset is offices. We don't, patient could be screaming all night, but we're not going to write for that drug. So we'll come in, we're basically user-friendly. We'll come in on a consultative basis, we'll assume the care, we'll do whatever it takes to get the patient properly cared for.
What do you do about chronic illnesses? Chronic pain?
We manage a lot of chronic pain. We use a lot of those things like methadone. We did have a primary care-based clinic. We've tried a number of things in our hospice, and a number of them haven't worked, and that's one of them. We became a default pain service and difficult to serve service. And we couldn't discharge a lot of those patients, so 10 years later, I'm still seeing them. So they weren't, and the problem with that is they weren't necessarily true palliative, and they weren't ever going to go into hospice. They were going to live for 50 years with pain, and nobody wanted to write anything for them. Our largest pain practitioner in New York is in Western New York in our area, and he's going to prison. And not because he did horrible things, but because they're cracking down so much on prescription drugs. Yes?
Just wanted to say I'm proud that in our IDGs, our IDTs, we do brief them first.
Yeah.
Really?
Yes.
I'll take that home.
Actually, meditation first, and then.
Well, you're California, you can get away with that.
It's the whole
No, that's really nice to hear because somewhere it got lost. We lost it.
We've lost it in the past, but we brought it back around.
Oh, did you really?
Well, yes. And I just wanted
I think
to
that's so important for the staff.
Yeah, and you know, sometimes people do die while they're on palliative care before they ever accessed hospice care or came to hospice.
Yeah, we lost over 100 last year in palliative care.
Wow, yeah.
You know why? This is interesting, because they don't want to give up the nurse.
Yeah.
The social worker.
Yeah,
I
that
can
could
see
be a
that.
problem.
I can totally see that.
Yeah.
I just moved here from, I was working for a cancer hospital in Huntsville, Salt Lake City, and they have a palliative, I work for a palliative I worked for the Huntsman Cancer Center in Salt Lake City, and they
Is that
have-
Perry Fines?
No,
Okay.
no.
Anyway, but there was a new program I started a year and a half ago doing hospice and palliative care, and so we did find that because we were one set of nurses for palliative and hospice, and then we had some patients that didn't want to give their TPN, so they would die in our palliative service, but we got rid of that transition because we were palliative and hospice, so we didn't have to give up the nurses, the doctors, the nurse practitioners, any of that as a transition.
We can't because of licensure. It's hard to explain, but we can't. Who's ever writing the check, they have to actually be employed by the hospice. If we put them palliative care into the hospice, then they'd be under the regulations. Put it under the regulations, it changes everything.
Yeah, it was definitely a regulatory challenge for sure. So, because we were employed, like the nurses were employed by the hospice agency.
That makes the most sense.
It was, so
Yeah.
we were employed by and then the nurse practitioners were employed by the Huntsman
I
Cancer
see.
Center. And so, but it was definitely a challenge. They've only been doing a year and a half, so there's a lot of kinks with it, but we found we got rid of that properly.
Yeah, that's what we would prefer. We just can't structurally do it.
Mhm.
Yes?
Can you say more about how, I think you said some of your palliative care patients pay a monthly fee?
No, the payers pay us a monthly fee. Yeah. So, so just a per member per month fee.
Do you have the contract with Medicaid?
Yeah, we do have, just started.
Yeah, we have had ours about a year now.
Yeah, it's great. It's a battle.
Yeah.
But the nice thing is allowed us to extend it into the peds world, which has never happened. And we're actually introducing a bill at our state assembly to see if we can get a palliative care provision for children, because children don't access hospice. So we have about 100 kids in our palliative care program, and at any time we have 1 to 2 in our hospice program.
Can I ask an elephant in the room question
Yeah.
of how your agency's responding to coronavirus? Sorry.
No, by not letting somebody like me have any say in it for one, because they keep me out of it. I would mess this up. I mean, there are ongoing communication to staff from our New York State Department of Health of what to expect, what to look for. I think where we're going to get into trouble is access into long-term care facilities. Our biggest fear is that we're on the verge of shutting schools and then daycares, okay? And we're, our employee demographic is such that a lot of them are mothers taking care of children. So I just don't know how we're going to care for all the sick people with so many people who have to be home. So that beyond that, that's kind of all we can do at this point. Unfortunately, we're behind everybody in the world with access to testing. We don't know true incidence rates. There's obviously a bundle of folks who are subclinical and incubating and percolating and all that, so I don't think we'll know. Yeah, that's the tragedy here. Is I think that the absent information is greater than the known information. Yeah, but I'm sitting with my daughters in a hotel coughing up a storm now, so I got to get her tested and seen. I don't know, what else can you do really? Social distancing?
Yes.
I just had one thought on some solution if the schools close down and stuff, is that maybe we're gonna have to just get rid of the 8 to 5 business hour thinking and really just kind of become more of a, like maybe a nurse comes in at 4 o'clock because
Yeah.
husband can come home then, and then, you know.
Yeah, I was talking to
see
a
their
social
patients
scientist
before.
about that this actually may change our concept of how we work, because we may be remarkably surprised at how much more we can get done. Like if they want to get the most dollar out of me, I know it's on these trips, because if I'm in a hotel room, I'm uninterrupted. But you wouldn't think of working from a hotel room. Anyways, if I am quarantined though, if I had to be quarantined in Buffalo or Santa Barbara,
We're out of toilet paper though.
yeah. Are you seriously? Yeah, there was an article written about the psychology of that, actually.
I've got some, I'll sell it to you.
$10 is over.
15.
Any, was this helpful at all, or nothing you didn't know? Okay. You know, if I can just finish one thing? The reality for us is our hospice has hit its ceiling. We capture, 40% plus of deaths in our community, which is actually fairly good. But we'll always have competing. We had a cancer center where it was America-like thing that was selling hope, and no one died of cancer, so that hurt us for a while. Now it's hormonal therapy. There's always an obstacle to hospice entry, dialysis, whatever. And so our concern was we weren't budgeting length of stay, access, percentage of deaths. So this allows us to do that. I really believe in it. So thank you.
Thank you.